I'm Sandy Collier, and I'm your host for this evening. Let me apologize for us being a little late, but we wanted to make sure that everyone who wanted to join us was able to be here with us this evening, because this is such an important topic. Black and brown people in South Florida are under attack by the devastating opioid epidemic. In fact, the latest government data shows that 128 people in the U.S. die every day from overdose at a cost to the healthcare system of more than $78.5 billion. But the cost to families is even greater. The T. Leroy Jefferson Medical Society sees the rising crisis and is stepping in to help. Tonight, we're launching part 1 of a new 5-part series on opioid prevention education, where we aim to provide groundbreaking education, awareness, understanding, and solutions for doctors, community leaders, families, and patients. But before we get started, we have a message from our executive director and then a message from our board president of T. Leroy Jefferson Medical Society.
Hello, my name is Laurel Dalton. I'm the Executive Director for the T. Leroy Jefferson Medical Society. I would like to thank you for participating in our education series today, along with our wonderful expert panelists, as well as the Health Council of Southeast Florida. This activity has been planned and implemented in accordance with the accreditation requirements and policies of the Accreditation Council for the Continuing Medical Education through the joint providership of Florida Area Health Education Center Network and T. Leroy Jefferson Medical Society. The Florida Area Health Education Center Network is accredited by the Accreditation Council for Continuing Medical Education to provide continuing medical education for physicians. The Florida Area Health Education Center Network designates this live activity for a maximum of 5 AMA PRA Category 1 credits, 1 credit per session. Physicians should claim only the credit commensurate with the extent of their participation in the activity. The Everglades Area Health Education Center, provider number 50-3066, approves this program for a maximum of 5 contact hours, 1 contact hour per session of continuing education credit through the Florida Board of Nursing, the Florida Board of Dentistry, the Florida Board of Clinical Social Work, Marriage and Family Therapy, and Mental Health Counseling, and the Florida Council of Dietetics and Nutrition. Before we get started, I would like you to hear a little information about our medical society and our programs in the community. Most of these initiatives were made possible by grants and donations to our organization. We also have several gift cards that will be given out to attending pre-registrants by random number selection on the first live broadcast of this webinar. And at the end of the session, please scan the QR code or follow the link provided for the required assessment for your education credit. For those viewing live, the assessment will load immediately at the end of the session. Thank you again, and please enjoy this education session.
Hello, my name is Dr. Tiffany McCullough. I am a board-certified emergency medicine physician as well as a wellness physician. I am currently the board president for T. Leroy Jefferson Medical Society for the term 2020 through 2022. I'm honored to be here. T. Leroy Jefferson is made up of healthcare professionals dedicated to improving health and wellness, access to care, academic and career development, as well as being sure to create additional opportunities for the underserved community. With opioid deaths on the rise across all racial and ethnic groups, our society has elected to educate the provider community on opioid-related issues because, truthfully, a project like this aligns perfectly with our mission. This is a 5-part series, and it is made possible through a grant from the Health Council of Southeast Florida. According to the Centers for Disease Control, nearly 500,000 people, that's 500,000 people, died from overdoses involving any opioid. This includes prescription medication as well as illicit opioids. In recent years, nearly all racial and ethnic groups are affected, and everyone has really experienced a significant increase in opioid-involved related deaths. That includes synthetic opioids and manufactured opioids. With our overarching goal to save lives, we plan to educate medical providers to give them a comprehensive and holistic approach to teaching patients with acute and chronic pain. We aim to help providers. We are using a 5-pronged solution. These measures include improving their clinical decision-making, helping to enhance their patient management strategies, helping physicians interpret new clinically relevant findings, analyze health policy, and having access to resources for review. I'd like to thank you, our viewers, for electing to take this opportunity for additional learning. We would also like to thank our team for making this possible. We ask that you would fill out the brief survey at the end of this opportunity so that we can know how to best serve you in the future. A special thanks to the Health Council of Southeast Florida for making this project possible. If you would like to know more information about T. Leroy Jefferson Medical Society, please visit us at our website, which is tljmedicalsociety.org. Again, tljmedicalsociety.org.
I'm Sandy Collier, and joining me is Dr. Tiffany McCullough, emergency room physician.
Yes,
Thank you,
ma'am.
Dr. McCullough, for being here. So let's talk a little bit about opioids and how many opioid overdoses have you seen in an emergency room?
I would say hundreds, maybe thousands over the years. And I would absolutely say the number of overdoses that we see has increased significantly over the past 4 to 5 years.
So, Dr. McCullough, thinking about that, how can physicians know if a patient is in real pain or in the ER just to seek pain meds?
It's actually a difficult thing because when we use the word pain, it's actually a subjective definition. So it really depends on what the patient feels. You will have some patients that are actually what we call drug seekers, people who enjoy the side effects of the opioids in addition to the pain management effect. But then you have some people that are actually in pain. So it really can be difficult to ascertain. One of the ways that you can figure out is actually to look at the patient and to look at the the subjective clues, right? And then look at some objective clues. So some of your objective clues are going to be like the patient's heart rate, if they're perspiring, if they appear agitated. Right? So those are some of the ways that you can know if someone's actually in pain as opposed to someone who is just requesting pain medication.
So describe some of your experiences that you would like to share with other physicians concerning opioid overdose.
Well, so it can be a really difficult thing. So why? Because culturally we're different. So someone from one culture may experience pain or express pain in a different way than someone from another culture. In terms of opioid overdose and opioid abuse, the problem is that what we see is people having the long-term side effects. So I would say one of the ways that we can help prevent this kind of thing from becoming so significant and chronic is to limit the amount of opioids that we're giving to begin with, right? So you limit the possibility of addiction. The truth is that when people first started prescribing opioids, let's say when I was in residency 15 to 20 years ago, Tylenol number 3 was really the strongest stuff that we gave. Now people go home with Dilaudid prescriptions. So it's a huge jump, and part of it has been the pain management scoring that is required as part of patient satisfaction. It is important to address people's pain. It is important to treat the entire patient, but we also have to remember that we are responsible to the patient to not create an addiction. So I think that when you're evaluating someone and treating them, that you have to keep that in mind to not create the problem.
So what changes or improvements would you like to see in the medical field when it comes to opioid epidemic? And you just started touching on some of that. So what else would you like to see?
I think that it's super important for us to have other options for pain. My wish would be some non-addictive treatments for pain, for that to be more readily available. So we have things like radio frequency and biofeedback, but that's not easy for the average person to get a hold of. So I would love to see that kind of thing more available for the masses, right? And not for the people that can afford the payments or the co-payments or the private payments, right? So some of that type of stuff. Additionally, I think that education in general, just letting people, physicians, other prescribers know and really understand the dangers of opioids so that we don't start the problem. When someone gets hooked on Percocet, it's usually because someone gave them the prescription first. So to use non-opioid pain medications to relieve pain initially.
We have actually a lot of medical professionals listening to us right now, and you have a wealth of knowledge and experience as far as being an emergency room physician. What advice do you have for the medical professionals that are joining us?
You are doing a great job with everything that you're doing. As long as you keep the patient first, we can actually combat this problem. Some of the ways that we have to do that may include not giving pain medications all the time, but there are alternatives. So please make sure that you understand the alternatives so you can express them correctly to your patients. It doesn't always have to be an opioid.
Dr. McCullough, thank you so much for your service to our community. We really appreciate all of your knowledge.
Thank you so much for having me, Sandy. It was great.
I'm Sandy Collier. We'll see you again next time. I'm Sandy Collier, and joining me is Dr. Monica Walker. She practices family medicine and geriatrics, and Dr. Walker is also the chaplain for the T. Leroy Jefferson Medical Society. Dr. Walker, thank you so much for being here. Let's start by you telling us a little bit about yourself and your practice.
Thank you. Well, it's my absolute pleasure to be here today. I have been in this community for about 35 years. I practice, as you stated, family practice and geriatrics. It is a practice that I enjoy very much. We see people from age 16 to 100 years old. And we also do workers' comp claims and motor vehicle accidents and all types of things that involve injury and treatment. We also have a holistic approach to our treatment for all age groups, and it's just been a pleasure to work in this community.
And talking about community, Dr. Walker, we have a big topic, opioids. So What has been the impact of the opioid epidemic on the Black and Brown communities in years? Let's talk a little bit about that.
I'd like to start a little early on just for a historical perspective. We know that in the early 1960s, we had the Civil Rights Movement, and in 1964, we had the Civil Rights Enactment. So the question was whether or not this Civil Rights Movement and the Civil Rights Act of 1964 was going to make every American free and free indeed in terms of the social economic perspective of one's life. And so in order to do that, it had to be equity in terms of the amount of money that flowed through our communities. That did not happen. What happened was what was called by Richard Nixon, the war on drugs, and that was more or less rhetoric. And then subsequent to that was more execution of the war on, and I'm going to say euphemistically, war on drugs, which ended up being something quite different. So when Ronald Reagan started and had this execution on the war on drugs, it was more or less like the war on our community. It actually targeted people in our community for drug crimes, making the individuals who use drugs more of a target. They were arrested more. If we look at the general population of individuals who use drugs, people in the higher socioeconomic groups did not get arrested, did not get convicted, did not do jail time as contrast to people in the African American community. So it seemed as if, and I want those experts who know the history a little bit better than I do, but it seems as if there was a war on the Black community. And the reason I say that is because when we look at the individuals who benefited from it, we know that there were programs that were pouring into our community, and they were federal programs, so that meant federal dollars. And so when federal dollars go in, there are all kinds of groups. Law enforcement was more empowered because they received more money, and it was important for our community to see what was going on, and they saw it. So individuals were very vocal about harassment in our community. They were very vocal about convictions. They were very vocal about excessive jail time for using the drugs that were in our community. For instance, let me just give an example. And I know everyone knows this, but I just want to bring it to our attention again. Crack cocaine is what maybe some of the people in our community use because we know it is a stimulant. We know it's excessively addictive, but they use crack cocaine because it's less expensive. Powder cocaine was used by people who are in the Caucasian white community. And so the jail time for crack cocaine was a lot longer than the jail time for powder cocaine. And that's just one disparity that we see. The other thing that we see is that once someone is convicted of a felony, it is very, very difficult once they get out. And keeping in mind that the jail time, the actual time spent in prison is prolonged. Then when they get out, it is very, very difficult to have a decent life afterwards. Why? Why would I say that? Because one, you in some states are not allowed to vote, and there's a problem with getting a student loan. There's a problem with working for the federal government. There's a problem with getting loans, period. And so let's say, well, maybe this is just a mistake we made, and did not enrich anyone. But we know that it certainly did not enrich our community. It made our community poorer because you took these people who would be very productive in our community, and if they used or accused of using, I just don't want to say used, but accused of using a drug, then they were incarcerated. And once incarcerated, then of course they had to work very hard, if they were able to change that image. So for instance, if someone goes to get a job And on their record is, that they've been in prison for drugs. And so, of course, the employer is going to say, well, we need a drug screen. And I'm not sure you can really do this job because maybe the fact that you were in prison was lawfully so, even if it wasn't, lawfully so, and you're going to have to bear the consequences of that. But not even that. Let's just say that there are two people getting a job, and one is a 28-year-old white male who, is probably capable of doing the job, and then there's a 28-year-old black male. And so because the consciousness of the country has been so tainted that these people probably are criminals, they probably do this, they probably do that, and they can say that, oh, I unconsciously think that way, but when you brought it to my attention, I know that I was wrong. But it impacts the economic status of a group of people.
So, Dr. Walker, in our communities, can we get past this opioid problem? How do we fix this? Is there a fix?
Yes, there is a fix. So I think we're talking about two different things. There's an opioid problem where people are taking drugs and having problems with prolonged illnesses and, of course, overdoses and just a tremendous amount of death because of it. We are, in this country, probably the users of opioids more than any other country. So that's the use of the drug. The second part of the question is, who is being penalized more? Is it the people who are in the upper and middle class area, or is it individuals who use a form of opioids that are not? So we know that heroin is a form of an opioid, but of course it's cheaper, and we see heroin more in the African American community. So yes, we can get past this. First of all, we have to change the laws. We know that drug enforcement laws have been on the books in this country for the last 100 years. But I do believe that it was in 1986, and those attorneys and judges and people who know the law can tell us exactly the ramifications of that law. In 1986, it became more strict. And because of that, now we see that statistically, the majority of people in our prisons, our federal prisons, because of drug crimes are African Americans. 74% of the incarcerated are African Americans. They are stopped, they are brutalized, and then arrested for this. So there are two facets to this. One is the use and the overdose, and I'm sure a lot of my colleagues have already spoken to that, what it does to the brain, and we'll talk about that because that's a problem for everyone. But the thing that does not have to be a problem for everyone is the brutalization of our community because of so-called laws being broken using opioids or using the analogs of opioids. So that's a problem that I don't think has been addressed. It needs to be addressed. When we say war on drugs, we don't want to say war on our citizens, especially our Black American citizens, African American citizens, but that is what it has been heretofore. And we can change that through laws, through our protests, through the elected officials. That's what we have to do because we cannot turn away from those individuals who maybe don't have a voice the way we have a voice. And that is the double-edged sword that we have. One is the fact that people are being victimized because of it and economically deprived because of it. And the other one is that there's so much in our communities that people are overdosing. Not young people, not old people, not Black people, not white people, not rich people or poor people. Everyone is being victimized by that. And I know probably my colleagues have already talked about Big Pharma and how Purdue, who was sued recently, pushed these drugs knowing how absolutely addictive they are, and of course they were sued, but that's just one way to do it. The other companies that are part of it have been just as guilty. So yes, we can do something about it. We can change.
So, Dr. Walker, you've talked about a lot of contributing factors to why we are where we are right now. What else contributed to us being here?
Well, the other thing I think is important for us to realize that we are in this position that we're in now because the pharmaceutical industry has promoted these drugs as being initially innocuous, that they were not that addicting, that they were just for pain use. And the pharmaceutical companies also wanted to say that we need to address everyone's pain. So the promotion was that pain would be the fifth vital signs. So we would have the blood pressure, the pulse, the respiratory rate, the temperature, and oh, what is your pain level? And whatever they said their pain level was, then that would have to be addressed. That did not come from medical school. That did not come from our professors. That came from the pharmaceutical industry. The fifth vital sign being pain. That was one thing. Then the other thing that happened in the industry, and it's no secret because the lawsuits are there, is that these companies sent their representatives to woo the doctors, not only to write the drugs, but to write the drugs at the highest level, because that's where the profitability was. That's where the money is. And so when you see the evil in this entire epidemic, it is not just the people taking the drug. They would be the most innocent. The drug companies will tell you, we can't sell and make drugs for people who are only those who have cancer, only those who are in stage, only those who are riddled with pain, because we can't make enough money. We need to use these drugs on people who go to the dentist. We need to use these drugs on people who have a little fender bender and their back hurts. Well, let's just start them on an opioid. And that is the problem, because it is the love of that money that is the root of this evil. It's all about how much money, how can I make the money, and who will be able to help me in my effort to make the money. And that's why we see the lawsuits, and that's why we see a lot of other devastation in this area.
Dr. Walker, thank you so much for being here, and thank you for sharing for us today, and thank you for everything that you do for your community.
Well, thank you so much. It's been quite a pleasure being here today.
I'm Sandy Collier. We'll see you next time. I'm Sandy Collier, and joining us for this session is Dr. Chadwick Hampton. Doctor, thank you so much for being here, orthopedic surgeon. Tell us a little bit about yourself and your practice.
Well, thanks for having me. Again, my name is Dr. Chadwick Hampton. I'm a board-certified, fellowship-trained orthopedic surgeon, practicing adult reconstruction, hip and knee specialist. My main practice is in Palm Beach Gardens, but I also have an office in Wellington. A little bit about my background. I was in the Army. I trained in the Army in Walter Reed Military Medical Center in D.C., and then started some time in Korea and Germany before I came down here.
And you are one of
two African-American orthopedic surgeons that is currently practicing here in Palm Beach County.
Wonderful. So, doctor, as an orthopedic surgeon, what are the guidelines for orthopedic surgeons in terms of prescribing opioids?
Well, specifically, the American Academy of Orthopedic Surgeons has worked with the CDC, and they set forth guidelines about prescribing or treating acute pain when you're postoperatively or preoperatively. Acute pain guidelines, they want to keep prescribing limits under 7 days, so a 7-day max. And actually, the country has changed. There's now state regulations, state by state. Not all states have adopted these practices, but most surgeons have to be a pain management specialist to prescribe chronic pain or to prescribe over a 7-day period or course. So if you're not one of those specially trained doctors anymore, which I am not, I'm limited to a 7-day course of treatment for acute pain only.
So, doctor, what are some of the alternative treatments to opioid prescriptions?
There's a lot of alternative treatments out there. Let me just speak to my practice. So I'm a hip and knee surgeon. So for preoperatively, when I'm going to perform a knee replacement on a patient, I give multiple medications. to include NSAIDs, so like Motrin, Tylenol, this is a good pain reliever. It's not an anti-inflammatory, but it's a good pain modulator. Gabapentin, which is a nerve pain control modulator, modulates nerve pain specifically. Steroid, I give a dose of steroid preoperatively also. And then we do the surgery. In the surgery, our anesthesiology colleagues perform nerve blocks and peripheral anesthesia or epidurals. So there are different options that our anesthesia colleagues offer us. So we give an epidural. We're able to numb both extremities below the knee. And then, secondly, we can perform specific nerve blocks to pick off specific nerves. So then afterwards, I do the procedure. On the way out, I'm able to actually inject a cocktail of different medications within the soft tissues on the way out after doing the procedure. All of these things combined are a multimodal approach, which is totally different than how we were trained or taught to treat pain as an orthopedic surgeon.
So, talking about training, as a surgeon, what training did you receive pertaining to prescribing opioids?
I think you might find this surprising, but we received no formal training during orthopedic residency, which is our training programs, during our training years, which usually is about 5 years. The reality is we got trained by pharmaceutical companies. So the pharmaceutical companies marketed very heavy. They would come to the office, to the residency programs. They give dinners, talks, and basically they were the ones that were teaching us that opioids are good, or this is what you should give to your patients for post-op. And then on the flip side, as a training resident, you had a staff. Your staff was like your mentor. He or she is passing the knowledge on to you while you're in training. The staff and the higher residents would basically tell you, I don't want to hear about the pain. Make it go away. So without saying it, they were telling us to just prescribe. Make the pain go away. We don't want to hear the calls. We don't want the calls coming to the office about pain. And that's kind of how we learned to treat pain in residency. And this is a fact. I don't have the source, however, but the majority, over 50%, the majority of patients had their first interaction from a prescription from a doctor. They didn't go to the street to get it. They had a car accident. They had surgery. They had whatever, and then they went down that slope. So,
Well, doctor, we have a lot of professionals listening to us today, and you've got a wealth of knowledge. What advice do you have for them?
specifically, listen to your patients. Go back to medical school. History is one of the biggest things. History and physical exam. Nonverbal cues you can pick up on, specifically when patients come in and they're asking for a specific medication or they're asking for a specific dose. That's a cue. Use your colleagues. Our anesthesiology colleagues are fellowship trained, some of them, in pain. So I use them and refer to my pain management specialist often so that I'm not stuck actually managing the pain, because I'm not actually up on the latest and greatest of all the pain modulation for in terms of all the pain. I'm very specialized in what I do in terms of orthopedics. So I often rely on our other colleagues and refer out to pain management, and then also try to follow the guidelines. And in our state, you don't really have an option. You have a 7-day course for acute pain treatment for a physician who's not a pain management doctor.
Dr. Hampton, thank you so much for being here, and thank you for your service to our community. We'll see you next time.
Hi, Sandy. It's a lot of great information that I saw so far. So this is a really, really good opportunity. I spoke about several different types of like alternative pain management options. One being biofeedback, another being radio frequency. Typically what patients do is, or you would kind of dial up. So you'll first try, and these are for more for chronic pain, as opposed to just an acute pain, like someone that was in a car accident or something like that, that just has pain immediately after. What we typically like to do is to see people, try alternatives such as physical therapy or steroid shots and maxing out on anti-inflammatories. After that, if those things don't work, then going up to things like biofeedback. Biofeedback specifically is just the process by which you are able to identify painful areas in your body, and you learn to focus on subtle clues that help you to reduce those painful areas. Radio frequency is another, I think, really important non-opioid type of pain relief, where it's simply a minimally invasive procedure that burns the nerve.
So we have another question for you, Dr. McCullough. As an emergency room physician, do you work closely with other healthcare professionals, such as pharmacists and nurses, when making the decision to prescribe opioids to patients? And if so, can you walk us through that process?
Absolutely. So, in the emergency department, you typically work in silo. It's kind of fast paced, and there are a lot of things usually going on at the same time. With that being said, as a person is in acute pain, and or if you have difficulty managing that pain, you definitely do rely on your other professionals, people who are experienced as well as you, to really be able to treat all aspects of that patient. Specifically, I'll give you an example. If you have a patient that comes in with a gunshot wound, and they're in pain, and meanwhile you're ordering labs or x-rays or speaking with consultants, the nurse is the person that's going to be at the bedside saying, oh, I think everyone works in collaboration, but ultimately our goal is the same, and that is to treat the whole patient.
Wonderful. I think we have a question for Dr. Hampton. So Dr. Hampton, how early should healthcare professionals be educated on opioids? Does it start in college or during nursing or medical or pharmacy school? Can you talk a little bit about that? Dr. Hampton?
Yes, sure. Thanks for having me tonight. Medical school is an appropriate place to begin when we're doing our basic science and pharmacology training. I think that's where we should begin, getting the basis of understanding opioids, how to use them, the dangers. I don't believe that opioids should not be used. They need to be used appropriately and under appropriate conditions. Like I said previously during the evening, I was trained basically by Big Pharma. The big pharmaceutical companies had a big imprint on residency programs. So they spent a lot of money coming to the residency programs, taking us out to dinner, doing talks, spending money in basically putting in our head that opioids are a great way to treat post-operative pain in the surgical or the perioperative period. We did not get formal training from our medical school on opioids other than just the pharmacotherapy, meaning the science of how the drug actually works and the interaction on the human body, but no formal training on the aspect of addiction and tolerance. So the reality of the situation is you end up learning it on your own. I have gotten to the point now where I can do total hip and total knee replacements, opioid less. I have a few patients that I can put in that pathway, meaning I give preoperative medications, 3 or 4 medications, no opioids, intraoperatively, multiple medications within the soft tissues before I close the wound. And then postoperatively, I can control most patients, about 85% now, not using opioids and using Tylenol, some type of nerve medication, and NSAID. So that's how I've changed my practice. My practice is 80% opioid free. There's about 20% of patients that I just cannot achieve that with yet.
Well, Dr. Hampton, you just really answered the next question that was here for you. It says, when patients have had extensive surgeries that require pain management, how did you manage their prescriptions of opioids? And you just answered that. Is there anything else you want to add to that?
No, but yes, actually, excuse me, education. The level of education and preoperative knowledge of their pain and what the procedure is going to entail is key. If you set expectations preoperatively of what the pain is going to be, how that is going to improve, you're going to have pain at this level for these 3 days. You're going to have pain at this level for the next 2 weeks, and then at this level for the next 4 weeks. If you set the appropriate expectations, you can manage it without opioids for, in my practice, about 80% of the patients. Now, again, this doesn't go for everybody. There's a decent amount of patients in my practice that they come to you and they're already on opioids. They've been dealing with knee or hip pain for years and have been on opioids or pain management for years already. And for those patients, it's just not going to be possible. But for 80%, it is.
Let's move on to Dr. Walker. And Dr. Hampton, I want you to stay right there because I think I have another question coming in for you. Dr. Walker, will you elaborate, please, more on this statistics that African Americans incarcerated for drug-related nonviolent crimes? Can you started sharing a lot of that with us. Can you talk a little bit more about that?
Yes, thank you. And this has been a wonderful program. Thank you. The United States Bureau of Census estimates that there are about 44 million African Americans in the United States, which is about 13.4% of the population. But in our prisons for nonviolent drug-related crimes, there is almost, I'm going to say, twice as much. So the research shows that African Americans comprise about 62.7% of those who are in prison, and Caucasian whites about 36% of all drug offenders admitted to state prisons. And the federal surveys also bear this out. So it is important for us to have a little bit more statistics and then to figure out why this is happening. So that mass incarceration of nonviolent drug offenses, it's what we see, and the people who are actually stopped and frisked and detained and searched are overwhelmingly African Americans. The statistics further say that African American males 18 to 35, 25% of them are in jail now. And a lot of that is just related to drug use. The statistics further tell us, and I think I'd said this a little bit already, but I'll just further elaborate. When this started with President Nixon, the war on drugs, it was rhetoric, but Reagan actually declared the war on drugs in 1982. And interestingly enough, in 1982, there was not an increase in drugs. Only 3% of the country was thought to be impaired with drug use. But after that, it truly escalated when there was a lot of politics involved, of course, and a lot of money. In 1990, President Clinton had just continued the war on drugs. And during that time, the use of marijuana was thought to be something that would not be tolerated, although we know it's very different now. And then there was quite an escalation of individuals who were in prison just for using marijuana. So we know that this reason for imprisonment can be tied to prisons that are for profit. And if prisons are for profit, they need to be filled at capacity. So I think our community really has been looking at this very critically. There's a school of thought that we should decriminalize the use of drugs, and that particular group of people compare it to the 1920s with prohibition, and of course all the gangsters and that kind of crime that was in the 20s because of alcohol. Once alcohol was legal, then that type of crime ceased. So I think they have a point there. We just have to explore that more.
Let's talk a little bit about pharmaceutical industry. You speak about the pharmaceutical industry and how the prescription of opioids, even for what could be considered minor pain, has been aggressively promoted, notwithstanding the medical evidence that suggests that perhaps they should not be, especially when the risk of the addictive characteristics of opioids are taken into account. My question is that from a regulatory perspective, we often speak about patients needing protection from predatory behavior. Do you believe that doctors need some sort of protection from pharmaceutical companies offering financial gains for promoting their products? And in short, do we think doctors are victims of predatory behavior? And do we need to investigate the addictive characteristics of financial gain on medical professionals from a regulatory perspective? Now, I know that's a mouthful, but can you talk a little bit about that?
I think Dr. Hampton addressed it earlier. We were not properly educated, especially in my age group. I went to medical school in the 1980s, and so we were not properly educated as to the use of opioids. And he is correct that we had a lot of information from the pharmaceutical industry, but at this point, we do have regulations in place. I don't think that doctors are preyed upon. We are more astute in terms of what the pharmaceutical companies have done. And I stated in our piece earlier that the reason that the pharmaceutical companies went after doctors and, as Dr. Hampton said, kind of wined and dined them and had a lot of money poured into the residency programs to influence their prescribing practices was just because it was a big money producer. And that is it. So now, do we need to have, well, first part is, were the physicians considered prey and there are predators against us? No. Now I don't think that we are prey. We understand, we have a good foundation. We understand what we need to do to only write a few medications as needed, as Dr. Hampton said. And all physicians in this country realize that if we write more opiates than we should, that we will be looked at with scrutiny. And so first and foremost, do no harm. We don't want to do that. We don't want to get people addicted. And secondarily, we want to be able to keep our populations healthy. So no, I don't think we need to have oversight in terms of the drug companies having authority, or the drug companies not being able to talk to us about these medications. They can talk, but we are now well informed, well educated, and able to tell that pharmaceutical rep or whoever it is giving the lecture that no, this is not proper. This is what we're going to do.
Thank you for that, Dr. Walker. We have some more questions here, and I'm going to ask Dr. McCullough this question. What do you think, what will it take for insurance companies to ultimately cover non-opioid treatments?
That's a really interesting question. What will it take? I think that it will take the consumers to be educated and demand other options. Insurance companies are funded by the people that they insure. So I think that's really the big thing. I don't believe that the general population is really educated about non-opioid alternatives. I think that, we see this in, different socioeconomic brackets. We see this, with different cultures, that the expectation is if someone's in pain, they don't want to be in pain. Whereas what we understand now a little bit better is that there may be some pain that you have to tolerate. And so kind of changing our attitude as a society and as prescribers and as patients, understanding that there may be some pain, with a painful surgery or a painful situation, that has to be accepted, and also people rallying and demanding additional options be covered and making those options more mainstream as opposed to kind of these weird things out in left field. I think that those changes and attitude changes will really give us more options in terms of pain control, because they're there. It's not that these options aren't there. It's just that people aren't that willing to accept them as options for their pain management.
Dr. McCullough. Dr. Hampton, we have another question here, and let's see if you can answer. You can answer, Dr. Walker or Dr. McCullough. Any one of you can jump in. To what extent psychotherapy is being utilized to address opioid addiction, as it is a possibility, specific triggers that may have caused the patient to utilize abusive medications that may not be from physical factors?
Yeah, I can speak on that briefly. Just to the point is that's somewhat out of my scope of practice. Now, there are some clues or red flags, if you will, that I will send a patient preoperatively for if I'm, for example, let's say I'm have worked a patient up for total hip replacement because of hip osteoarthritis, and they have end-stage osteoarthritis, debilitating and lifestyle limiting. So we've decided to go ahead and proceed with total hip replacement. And on my workup, I see that they are taking a large amount of some specific opioid, and they have a couple other red flags that my antenna goes up. Then I may decide to send that patient for a consult for a psych evaluation per se, and a preoperative pain management consult, because I may anticipate having trouble managing their pain postoperatively. But that's at the level that I can really speak on that. I sometimes consult our other colleagues in that nature.
Okay, Dr. Walker, Dr. McCullough, do you have anything to add to that question?
Can you please repeat the question, Sandy?
Yes. The question was, to what extent psychotherapy is being utilized to address opioid addiction, as it is a possibly specific triggers that may have caused the patient to utilize abusive medication that may not be by psychological factors?
I'm going to take my understanding of this question. What I think the question is asking is, if someone has a trigger that's not necessarily pain to use narcotics, how are we addressing that? Is that correct?
I would think that would be my interpretation of the question as well, Doctor.
Okay, so you know, it's a really difficult place to be in. I think that it really depends on where you're meeting this patient. I'm an emergency medicine physician. I will see someone maybe for 15 to 20 minutes, you know, once a year kind of thing. So not on a regular basis. My interaction with that patient is kind of a snapshot. So my perspective will be different than someone like Dr. Walker, who is a primary care physician, who may see that patient every 3 months for that chronic hip pain, right? So I think that being able to connect with your patient, and then the same with Dr. Chadwick, he's seeing that patient, but you know, a portion of that time, if they go to the OR, that patient's not even able to say anything to him, right? Even though he is still caring for them. So I think that when you combine the many different types of physicians, it kind of creates more of a muddled picture. Not everyone that has pain needs to necessarily have a psychiatrist address all their pain issues. However, I think that if we are able to connect with our patients, like truly form a connection and listen to them, we're often able to kind of tease out clues as to the underlying cause of someone's symptoms, whether it's addiction or pain or shortness of breath or whatever their psychosomatic symptom is. You can kind of tease out some of the underlying cause. So I don't think that that's something that we can do very easily and readily, because it requires that team. So the team between the patient and the provider and, you know, all of the ancillary staff and help, that team really has to kind of all be in the same place and all on the same plane in terms of that.
This is our last question. Does any of you believe that one of the solutions of opioid crisis is to treat patients from a personal perspective, as in treating yourself? And that's from an anonymous person. So any one of you can answer the question.
To treat patients from a what perspective?
From a perspective as you're treating yourself. I guess I would interpret this question to be, you know, when prescribing opioids to a patient, would you consider, well, if this was me, would I be prescribing this? That's how I would interpret that question.
You know, that's really a tough question. That's whoever that anonymous person is. That's a tough question, because we are so different. Some people, like in the ER, you know, I've had people so terrified of needles that they would rather be sutured or have a wound closed without any anesthetic because they don't want to be stuck in the wound. I would never do that. So I think that we're so different that I think you have empathy for your patients. I don't think that you can necessarily treat someone as if they were you. Maybe treating someone as if you cared about them. I like to say that I try to treat my patients like my mother or my grandmother, you know, in terms of my caring for them. But that doesn't necessarily mean that I will or will not give opioids. Usually those are not related.
Thank you so much, Dr. McCullough, Dr. Walker, Dr. Hampton. Thank you so much for your knowledge. Thank you so much for everything that you have done in this community. And thank you for always being there. You're on the front lines. Thank you so much for your service. I'm Sandy Collier, your host this evening. We'll see you again on Thursday.